All right. So, I better not do that.
It's not your desk.
It's not my desk. I'm Doc Faisal, orthopedic surgeon with Move Smarter Health. We are sponsored by an educational grant from Kinesi Movement. I love sports. I love talking about injuries. I take care of shoulder and knee injuries, and I operate and treat on them. And please consider this an educational, informative video only. Here we go. All right, so what we know is dislocated. We don't have all the details about the dislocation and the type of injury. Was it the extent of the labrum, the Bankart, the extent of the Bankart? Was it associated with a flake of bone, no flake of bone? Were there any associated fragments, injuries, or ligament tears associated with that? We don't have any of that. Was there a Hill-Sachs lesion? Hill-Sachs lesion is basically when the shoulder dislocates, typically you get the front of the glenoid smashing into the back of the humeral head, and you get this depression. Think of it like a golf divot. So golf ball, oh, thank you. When it makes the divot right here, do you see the divot? Zoom in right there, there's a little divot. Right, so that divot is exactly what happens with a shoulder dislocation that goes out the front. Now, if it goes out the back, whole different story. It'll create a divot in the front or not. I mean, rare, much more uncommon to have a posterior dislocation, more associated with certain types of movements where it goes out the back or impact motor vehicle crashes, crashes or seizures that can result in the sudden posterior dislocation. And I think she caught an edge or something. It's still, she kind of landed like this. So which arm was it that dislocated? It depends on the mechanics of the fall, right? It's hard to see. It is left shoulder, yeah.
On here, it says right shoulder.
What?
Yeah.
My AI says left shoulder. Wait, this is weird. I would say that common things being common, if her arm is like this in the fall, on the right side, it's, a little more protected from a shoulder injury, but you can get a posterior shoulder dislocation. With this arm like that and the way she landed, I would say common things being common, it's likely that I could agree that it was the left shoulder, but again, we don't have all the details. We don't know which shoulder is. We're getting mixed news feeds, one saying left shoulder, the other saying right shoulder. Very interesting. And her own video doesn't really reveal which shoulder it is. Her own Instagram, where she describes her fall and her injury, don't say which shoulder it is. She's, in her 20s, right? 24, 25, I think 25 years old at this point. Young, elite, Olympic level, world-class athlete with a shoulder dislocation. So first of all, most of the data, when you're under 18, your odds of a repeat shoulder dislocation are high. So once you have a shoulder dislocation, your risk of another dislocation is high. So the tendency is repair early, reconstruct, stabilize, prevent the repeat dislocations, and get them back into their sport. Now, she's in her 20s. She is very, very high level. You don't get higher level than that in a sport than Olympic, gold, and world class level. So, and she's in an impact sport. Like, you can't call snowboarding a non-impact sport, right? It's kind of like, it's like, yeah, but they're not boxing, they're not hitting, it's not basketball, it's not football, they're not slamming into players, into each other, but they're slamming the ground, and there's always that risk. We've all tweaked our arms and shoulders skiing or snowboarding, right? You kind of take a little side swipe, you land. I've gotten lucky with no major shoulder injuries in that respect. Oh gosh, I've got the ski season. I just said that, didn't I? I just jinxed. Wow, you know what? It's such a bad winter season. I'm not going. I'm not going to go. My kids are going to be so mad that I don't take them skiing because of that comment.
Watch, next episode's going to be you like in a full body cast, just with your arms out.
We can mock that up.
welcome back.
Welcome back. Remember when I said? But you know, you kind of tweak your arm, shoulder, whatever. I mean, even like, you know, getting up around, you know. Anyway, so high impact sport, high level athlete, she's gonna get it fixed. You know, to be able to do what she needs to do and wants to do and does on a regular basis without thinking about it, she needs a stable shoulder, you know? I mean, even if you assume that, well, you don't need a shoulder to balance and land and whatever, but the mechanics of motion, mobility, balance, strength, rotation, when you're doing those flips, when you're going up and around, and to suddenly balance and stabilize yourself from near falls or even just balance yourself. Because, all right, so I better not do that.
It's not your desk.
It's not my desk. We better cut that out. So you're on a snowboard, right? Let's just assume your entire center of mass is here, right? You're lower to the ground, but just for the video, your center of mass is here, right? So this is your free body diagram. My arm is just a lever. It's just a plank of wood holding there and there. So at the tip, you have a gravity force vector going down. Same thing on this side. So they're balancing your arms to kind of keep you stabilized. So when you rotate, you create a torque vector that allows you to do those moves and those spins, right? So, so the mechanics of acrobatic snow sports are, you need your arms, you know? And I'm not saying anything against the Paralympics, right? Because there are some people that don't have arms, legs, and are able to compete. But you know, at her level, to be able to do the rotations, the movements, the acrobats, and the flips and turns and the balance to land really does require, you know, your shoulder for the stability. Now, if you have a dislocated shoulder and she decides, well, I'm just going to put I'm not saying that she is going to, I'm providing this hypothetical context. So let's just say that an athlete decides they don't want to get their shoulder fixed until after the Olympics because it's going to be a longer recovery, and they just put a shoulder brace on, and shoulder braces work in a very limited fashion. And there are limitations and restrictions about what you can do, but this is the worst position when you've had a shoulder dislocation for it to likely go out. So even if you have an unstable shoulder and you're waiting for surgery for whatever reason, you put them into a brace to keep them by your body, or at minimum like this. You do not want them doing this, okay? So, and that limit relates to the glenoid, the humeral head, and you don't want that popping off. It's essentially the shoulder joint proper is like a golf ball on a tiny little golf tee, and it's ready to fall off. The labrum is the bumper around there, and then you have some joint capsule around. You got muscles, rotator cuff, all sorts of constraints and tendons and muscles around there to rotate and move it around and act as accessory stabilizers. And then you have the suction cup phenomenon with the joint and the fluid and lubrication and cartilage and all that. Anyway, so, and the nerve and muscles control all of that. So, but imagine that it's just a golf ball on a golf tee. It's very inherently unstable. You take out the bumper, which is the front of the labrum, in the case of a Bankart, assuming it's an anterior dislocation, and it's torn. So then the golf ball can just fall off, which would be a shoulder dislocating, okay? So it's a high-risk sport, high risk of dislocation, young athlete with good ability to heal and recover. A month away from the Olympics makes it a very difficult choice for her. My feeling would be, if this were a patient of mine that came in at her level of sport with the injury that she had, and let's assume that it's a minimum significant labral injury. Let's assume it's a clean labral tear. And she doesn't have no other associated injuries, healthy as anything, ready to go to surgery, no significant swelling. You get her in, you repair, let's just assume it's 4 or 5 anchors, significant labrum, get her fixed, she's not going to make the Olympics. You know, the medical recommendations would basically be counter to what she would, or any athlete would want in terms of the recovery. Because the biology of the healing, 6 to 8 weeks, you want to let things stabilize. And there's, again, I'm not getting into the controversies, but some people believe you should, after a shoulder dislocation, keep the arm a little more neutral versus internally rotated because it puts pressure on the repair or the labrum itself. We're not getting into that. However, assume a traditional, you do the front repair, arthroscopic, Bankart repair everything goes perfectly, no complications, 6 to 8 weeks to heal, and then you start the rehab and recovery for strength and mobility. Because even if you get it fixed right away, there's the biology of healing. It's the human body. If you just have a piece of tissue tacked down onto the bone, it's not going to hold unless it heals. The way the body works is you need not just the reinforced concrete, which are the rebars and the rope, to hold the labrum and the soft tissue down, kind of like a suspension bridge, keeping it down. You also have to have the connective tissue, the healing tissue, the fibrous tissue, the fibrocartilage to then meld and glue that back. And until you have that, you can have micromotion, so it's not going to be a perfect gap like this. You're going to have this, and you zoom in. Let's create a little zoom in. So you zoom in and you see microscopic, nanoscopic micromotion in that layer between the tissue, and that in and of itself can create the lack of healing, or it can heal incompletely. So you have to have some level of immobility to hold it there temporarily, start some gentle passive pendulum mobility, active assisted, active full range of motion, and then strengthening your shoulder up in a full circumduction. You know, you got to have your full motion. So those are the challenges of the recovery within a month from the Olympics. And I'm not a betting man, so I'm not going to bet. But all I will say is that if it were a patient of mine that came in with a dislocation at a high-level athlete like Chloe is, my recommendation would be that against going into the Olympics with a repair. Let's assume a repair happened within a few days of her injury. You don't have enough time for the healing, recovery, rehab, and proprioception, neuromuscular retraining and kinematics and memory, mental aptitude that you feel confident that you're not going to throw your shoulder out again. Because if you've had an injury, there's a tendency to kind of like protect against it. You got to get over that fear. Even as marginally small as that fear might be, you know, we're not all Alex Honnold, right? And even Alex Honnold, he had a couple of bad falls. You know, he had a bad fall even before he ascended Half Dome. You know, but if you have an injury, it kind of limits what you can do.
So she can't go without surgery?
So I'm not saying she can't go without surgery. Okay, so I mean, if we talk about Chloe Kim.
For the Olympics, if she doesn't get anything done, how could she do that?
Okay, so you're asking a question of whether someone should or shouldn't, or whether they can. So here's the amazing thing about athletes. They're super athletes. I have seen some people do incredible things with their bodies, even though we believe in the medical profession that they can't possibly do something. I'm not a betting man. I sort of look at benefit risk. So the risk for a repeat injury, dislocation, and a not being able to do what she can with a dislocation is, in my opinion, higher than if she didn't have a dislocation, right? So the risk is higher. So, you know, should she do something? Well, that's Chloe's choice, right? I mean, it's your choice. If you have a dislocated shoulder and you decide to go skiing, snowboarding, or whatever you want to do, that's great. Because after the shoulder dislocates, within a few weeks, you feel like you've got the mobility and you feel like, okay, I can do this. But when you're put in a position where you have your shoulder in that position or impacting, that risk of dislocation is higher because you just can't heal soon enough. But I've seen some incredible people healing. Let's assume you take the best regenerative technology and assume it works perfectly. Could someone go in there and inject in Switzerland? She's in Europe, she's in Switzerland. She has access to medical care that isn't available in the US because the FDA is very different than CE mark, right? So there's a big difference in how things are approved and cleared in the US and Europe versus the US. So regenerative technology, go in there, put a little, stem cell, regenerative cells, injected, localized it right into that area. Don't do the surgery and just get her just to heal up and function. Could she do that? Well, I'm never going to say never. The odds are, in my opinion, is that it would be a high risk for another injury. It's not, sidestepping the answer. It's just being a realist and a pragmatist in terms of what is reasonable to say to patients, right? And now, because a lot of what we have learned in medical science has come from patients doing things that we don't think they should do. And when they do something that's incredible, we say, wait, how did that patient do that and that patient didn't? And we see a completely different opinion in how some surgeons in Europe treat things very differently from surgeons in the US. Range of motion is a great example. I had someone have their knee replacement in Europe. They were told not to move and do very little early on. Keep the knee quiet, let it heal, don't get too aggressive. Don't push yourself too hard. Let things calm down. Let the swelling down and gradually start moving. In the US, we get them moving right away. We get them mobilizing. We get them on an entire, non-narcotic pain protocol to get them up and moving and out of the hospital, outpatient surgery, out. Very different from some facilities in Europe in terms of the rehab and progress. And there's arguments both ways, right? So it's hard to say whether someone is going to be in the Olympics, should be in the Olympics, or will be in the Olympics. I know you don't like that answer.
I do. That's good. So she'll probably do it because she's a baller.
So if it were you or me, we're not in the Olympics anyway. But if I had a shoulder dislocation, pop it back in, I'm older than 40. I'm not going to say how much older than 40, right? You can see I got a little bit of thinning and some gray hairs. I'm definitely older than 40. That's all you're going to get, right? So pop the shoulder back in. I'm like, I'll be fine. I'm going to skip the ski season this year. I don't do anything aggressively with sports, but I do like to do handstands. I do like to do push-ups, like 20, 50. Haven't quite hit 100 yet again. But I like to push the upper body mechanics. I like to swim. So I have to have that discussion. But I'm not going in the Olympics in 4 to 6 weeks. But she is. She may decide she's going to take that risk. If she doesn't have a bony Bankart, which means that a big chunk of bone broke off with the labrum, if she doesn't have a big Hill-Sachs lesion that puts her at increased risk of instability or a locked dislocation. So if you imagine your shoulder pops off, does this, and all of a sudden now it's got a divot in here. So then if it dislocates again, it can get locked and stuck instead of gliding smoothly. So if she has, say, less than 20% of a Hill-Sachs lesion, less than 30%, the numbers can be all over the place. It's almost sometimes not random, but it's arbitrary based on biomechanics done in a lab in terms of what is or is not safe zone for shoulder mobility and function, right? And so if it's more than 30, 40%, is it 20%, 30%? The numbers vary depending on various studies. And if her bony Bankart is less than 10%, 20%, whatever that number is, more than a centimeter, under a centimeter, to what part of the pair of the glenoid does it involve? What portion or quarter or quadrant of the glenoid is involved? And there's so much data on that. But in the end, if it's a decent chunk of bone with a decent Hill-Sachs bony divot in your humeral head, with a large labrum, let's just say it goes from 12 o'clock all the way down to 6 o'clock. I mean, sometimes you don't have a labrum attached within the 12 to 2 zone because of some variance of normal, but definitely all the way down to 6 o'clock. That's a pretty large tear with a bony fragment and a bony divot, high risk for dislocation. Let's just say it's a small tear. Let's just say that on the MRI, it looks like it's sitting in a good position. It's not completely off. It's not locked. There's no bony injury. There's no shredding of or delamination. The cartilage appears intact. And she keeps her arm in, let's just call it a gunslinger. Again, different theories. Some people say this, some people say this. Some people, do all sorts of different positions for your shoulder. That is bad. This is conservative. This is a certain trend for the gunslinger where you have it slightly like this so the labrum sits in a neutral position. And let's just assume she gets a shot of the most amazing top regenerative tech. Repeats her MRI a couple of days before, and she says she's going to go. That's her choice. That's all I can say. Benefit risk.